Welcome to Medical Grand Rounds. Thanks for joining us. I'm David Schwartz, Chair of Medicine. This presentation is going to be recorded for future reference. You will be muted when you enter the meeting. At the bottom of your screen is a Q&A icon. I'd like you to try to use this icon rather than the chat feature to submit your questions. It's a lot easier for us to field your questions and organize your questions and serve them up to the speakers. I'll moderate that question answer period at the end of the presentations. So the experience of caring for patients with coronavirus infections is emotionally complex and at times overwhelming. The emotions range from grief and isolation to fear and frustration to gratitude and camaraderie. As frontline providers, we've worked for months in a data-free zone and continue to face an uncertain future. All of us are in need of emotional support. And that's why we thought a Medical Grand Rounds focused on the mental health in the time of COVID-19 would be an appropriate topic, especially at this point in time. Today, we have 4 outstanding speakers with expertise in this area. The lineup includes Dr. Stephen Berkowitz, the director of the START Center in the Department of Psychiatry, Dr. Charles Benight, director of the National Institute for Human Resilience, Dr. Brook Griese, co-founder of Judys House and the JAG Institute in the Department of Family Medicine, and Dr. Neill Epperson, professor and chair of the Department of Psychiatry. So let's get started with Dr. Berkowitz.
Well, good afternoon, everyone. I'm going to do a brief overview of what we know about responses in disasters and pandemics, and a little bit about the current experience we've had here at Acute in terms of healthcare providers. So one of the things that is important is to understand the difference between disasters and pandemics. Disasters can teach us some, but not a great deal. So here's what we know. One of the differences is that disasters are localized, they're singular events, and the long-lasting impact is on those people who are directly affected. And most survivors will recover and return to their baseline functioning, but the risk factors that have been identified are low socioeconomic status, and I should say that is the #1 risk factor, and then loss of home or community. Those people who are displaced are at much greater risk. The common outcomes that we see that are negative are drug and alcohol dependence increases, and #1, depression is 2, anxiety disorders, and PTSD is actually 4th typically. Again, it depends on your exposure. Another thing that's been understudied, and Dr. Griese will talk to us about, is complicated grief related to loss of life and resources as well. So pandemics differ in that everybody's affected, large numbers. The threat to life is prolonged. Illness and mortality come in waves, so there's more uncertainty, more unknowns. Are we through this yet? No, we're not. Yes, we are, as I think we're all been experiencing. And then this, erosive stress effect that goes on, and I think we're all feeling. I have compared it to a version of the Chinese water torture. And a little bit, the last major pandemic, there have been many, as you all know, throughout all our lives, but the Spanish flu, the ill-named Spanish flu, the 1918 flu, about 28% of the population were infected in the United States, and almost 1% died. So that's very different than what we are experiencing now, and we'll talk a little bit about that. Not surprisingly, there's almost no data or research on the mental health outcome of the Spanish flu. The one well-documented data came from a large asylum in Norway, where there was a 7.2 fold increase in first-time asylum admissions over the 6-year period after the pandemic. I think that is informative, and I think this is something that we'll be seeing over time. Some of us consider the mental health crisis to be the next wave of what we're going to see in relationship to the COVID pandemic. The symptoms that were reported, and again, there was no DSM or diagnosis that was consistent, but with sleep disturbance, depression, what they call mental distraction, dizziness, difficulties coping at work. And I know you're seeing this as well, but there was a very large increase in delirium and neurological effects. All sorts of movement disorders and overall emotionality, almost frontal release syndrome kinds of things that we're seeing. And I should say there are some increasing reports of that recently. One of the big differences for us, though, as healthcare providers is that the expectations are so completely different, both from the community, but also for ourselves. There were no antibiotics, there were no ventilators, there was no expectation that if you were hospitalized, you were to be cured. That was not the expectation. We didn't have codes in 1918. We didn't have struggles with end-of-life issues. We were used to people dying from infection. Diphtheria was an epidemic that occurred many times. And then, managing families, that wasn't an issue. We didn't isolate families from their dying or sick loved ones. We didn't realize that was important, but it was a real problem. Then there are the ethical issues, which fortunately seem to have resolved, but, the life and death issues, who gets PPE, if there aren't enough vents, who gets those? And then certainly, while remarkably, the primary caregivers and health caregivers were again women during the pandemic. We have many more expectations of women having dual roles of sharing responsibilities, and this puts a lot of stress on people that didn't really seem to occur at that time. This is a paper out of China. It is basic, not tremendously detailed, but I think important. They had a large number of respondents, and they measured sort of the impact of COVID. And the majority said that it had a moderate to severe psychological impact. And then looking at depression, anxiety, and stress, again, a large number of people were experiencing depressive symptoms, though mild, though some moderate and a few severe. Anxiety was more so of an issue. Again, you can see those numbers. And then in another study, there was of hospital staff, there was a dramatic increase in depressive symptoms in that hospital staff, though that was not well documented. Here's some of the things that we're hearing about from healthcare providers. That's on the left side of the screen. Increased worry or anxiety, low mood, sort of feeling like they're never rested, they're never able to kind of feel happy about things. What we are hearing a lot about is sleep disturbance. And even those people who say they are sleeping during the night report that they're not feeling rested when they wake up in the morning. And I think that's fairly ubiquitous. And another concern is the increased use of alcohol and THC, which we're also hearing about often to sleep. So the concern is that the long-term impact of some of these things will result anxiety disorders, from worry and stress, low mood, depressive disorders. And we know that cumulative stress or chronic stress is a significant pathway to depression. Sleep disturbance is a predictor of all sorts of concerning psychological and psychiatric symptoms. And the other thing that's a concern for all of us, of course, are things relational, whether it's divorce, separation, and frankly, I have been getting many phone calls about those issues, but also interpersonal violence and child maltreatment and neglect. It's really tough to have kids at home 24/7, homeschooling, and so on and so forth. And I think everybody is feeling that in some way, shape, or form. So what do we know is helpful? And Dr. Benight will talk a lot more about this. But one of the most important things is the connectedness, the help and support from friends and colleagues. And that has been shown time and time again that is a key preventative factor in a time of extreme stress. So I encourage everybody to share authentically with friends and colleagues. Develop a structure to do so. It's, when you're busy and feeling like you have a million things to do, unless it's scheduled in and planned in, it goes by the wayside. And we are, as many of you know, supporting groups throughout the hospital system and facilitating them to work on that. Having your check-ins from managers, clinical director, so on, go a long way. How are you doing? Just a 3-second interlude, just checking in on one's, psychological state is really helpful. And also really scheduling in discussions with your family, whether it's at dinner time or another time, about how everybody's doing, what they're concerned about, what's new, how are we going to deal with this next iterative phase, things like that. And for your patients, and I know this is happening, and I'm thrilled, is really targeting those vulnerable patients that you have in your practices. Elderly, certainly, those who are isolated of any age. And I don't know if you saw the New York Times this morning, there was a huge article about young, single, and alone. And also those patients of yours with mental health issues. So just regularly reaching out to them and knowing that you're there and available is one of those keys to emotional support. And with that, I'm going to turn it over to Dr. Benight.
Thanks, Dr. Berkowitz. Before Dr. Benight gets started, I just wanted to make a general announcement that if you have questions, please remember to submit them to the Q&A icon at the bottom of your screen. Dr. Benight? Dr. Benight,
Yep.
Go ahead.
So I'm excited to talk to you all this morning. I'm the director of the National Institute for Human Resilience down in Colorado Springs at the CU campus down here. And the mission of our institute is really to focus on the human capacity to overcome and strength-based innovative approaches to clinical care, as well as cross-disciplinary research and community engagement. So we're very excited about being involved in this presentation today, but also with the state response to COVID. I'm going to be talking to you a little bit this morning or this afternoon. Can you hear me?
We can hear you, but have you shared your screen?
Yeah, I thought I had. Let me see here. There we go. Sorry, I thought I already had it. It hadn't gone through. I apologize for that.
Looks perfect.
Okay, so I'm going to talk a little bit now about some new data that's fresh off the press. This is not published data yet, but it is information that will follow up what Steve was talking about in terms of the China study. This project is currently it's headed by Dr. Andrew Smith with his colleagues up at the University of Utah. What this is a frontline provider survey, and it was based off of the China study. So the measures are pretty similar, if not identical. I want to just highlight the healthcare findings that we're seeing. This mood screen is basically depression. And what we're seeing is that, the bulk of the healthcare providers in the sample are doing fine with depression, not showing a lot of significant effects, but we do have some with moderate to severe, probably around 8% to 9%, I'm guessing right around there. You can see that firefighters, law enforcement, and so forth have pretty similar findings, with some with more severe. In terms of anxiety, this is where I think we're seeing more of the effects for healthcare workers, which makes sense. We saw that from the China study, and we're seeing it here with more people showing moderate to severe levels of anxiety. And with the type of workload, the challenges of the demand, along with challenges of home work-life balance, with being able to go home and have things normal at home, which they aren't. And then obviously the challenges of the COVID itself with the increase in deaths and so forth. And then as far as acute stress symptomology, again, we're seeing no severe levels in the healthcare population that we've sampled, but you do see about, again, probably 10% or 11% with some PTSD type symptomology in the moderate severe range. So that's important for us to look for later in terms of the uptick in actual PTSD diagnoses, and I think we will see that. I know this is a crazy slide, but it does point out something that's very important. This comes from a paper we published back in 2015 where we focused on burnout and secondary trauma. This includes both healthcare providers as well as just mental health providers, more specifically. But what we found in this cross-lag panel study was that job burnout really leads to secondary traumatic stress symptoms over time rather than the other way around. And that's an important thing for all of us to consider, because burnout is one of those insidious things that all of us could be experiencing at this point based on the demands that we've been under and that you've been under in particular. And that shield that is created by sort of having some breaks from work, some good rest in between, some solid self-care, those things have often at this point gone out the window. And as a result of that, the permeability of the person to burnout has increased significantly. And the characteristics of burnout that we want to watch for are complete and total exhaustion. Person will describe they have no energy, they're fatigued, and then also a depersonalization where they're going to work, they don't get any kind of satisfaction from being at work. They have a sense of almost despair of being at work, and then also lack of empathy for their patients. And so if you're having those types of symptoms, it's not uncommon, but just be aware that we need to think about that seriously, because it also opens you up to other secondary traumatic stress symptomology as we're getting exposed to these types of environments that people are dealing with today. So the burnout is a driver, and we need to be cautious of that and put in preventive efforts to deal with that. I just want to show you a little bit of what we're doing at the NIHR. We're connected all over the place right now, focusing on COVID, but also on other resilience-based projects. But importantly, we are linking with the Department of Psychiatry, with Neill and Steve. We're also working with the public health departments in Colorado, both locally in terms of the El Paso County Public Health, but also the state Public Health Department and Environment. So we're doing some collaborative work with all of these different organizations. The one I'm most excited to tell you about today is actually called the GRIT Project. We stood this up in end of March and worked with Dr. Joe Ruzek, who is a leader in the country on early intervention work for trauma and disasters. And Joe and I and a colleague, a person who works with me, Ms. Nicole Weiss, we put together a 5-hour curriculum training program that's designed to really enhance the overall community capacity to respond. And that can be a community in the sense of a hospital floor or unit. It could also be the hospital as at large, or it can be the broader based community. And we're training people right now in all of those settings. The 5-hour training program is designed to help people in their own natural community networks to be able to promote resilience with their friends, family, colleagues, and give them the basic tools to do that. So the 5-hour program teaches about some of what Steve covered today, the disaster stress issues, the pandemic stress that are specific issues, those for frontline providers. We also talk about strength and resilience and what does that mean, and how do we promote very important factors within this context, such as safety, hope, connectivity with loved ones, self-efficacy, collective efficacy, and so forth. And within that training, the individual is given the tools to how to make a contact with somebody. What do you do? So we get very, very pragmatic with this training, where people learn how to reach out to somebody, what to say, how to use active listening skills to respond, and then ultimately promote their strengths and capacity to handle what's happening. But also, if they're showing more problems, again, these are not mental health providers mostly. These are just general community members. What they are trained to do is give those people resources when they seem to be struggling more than not. And that can be basically technological resources, which I will talk about. But so far, we've fully launched April 20th, and we've now got, actually, it's up to 350 people who have been access to the training now. So since I made these slides, we've jumped quite a bit. There's also on the GRIT website, which is at grit.uccs.edu. We have podcasts, webcasts there to promote resilience, plus other resource information for different populations, such as healthcare providers, military, veteran, and so forth. We also have now what's called Grit for Ed, which is a training program that also is focused on the grit concept, but within school-based settings, working with teachers and staff from schools to help them over the summer to be able to manage the COVID process. And then we were developing a Grit Ambassador program. Again, this is what the program is focused on. I've just mentioned all these. I won't belabor them. And this is the one piece of the technological support that we're providing. We have a disaster recovery website that we've actually converted and customized to COVID. And you can find this now at myresiliencehelp.com. And it's a free 6-module system that's an interactive program designed to promote self-efficacy for managing the stress that's related to the pandemic, including also social support development and also seeking professional help. And that's all I have. So I'll turn it over to Brooke. Let me quit sharing here. There we go.
Thanks very much. Brooke, you all set? Oh, Brooke, you got to unmute yourself and share your screen.
The unmute part. Sorry about that. Somebody told me that we should have t-shirts that say, "You're on mute," for all of these Zoom meetings and presentations we're having. Can you see that now?
Yes, that's fine. Thank you.
Great. Well, thank you for having me today and for hosting this panel. I'm Brook Griese, co-founder of Judys House and JAG Institute, which is a nonprofit here in town that supports grieving children and families through direct service, research, education, and advocacy. I'm really thankful that grief was included in this panel because, as Steve said, it's often an aspect of mental health that is overlooked. We're a pretty death and grief avoidant society in general, but as we know, grief is all around us right now. And so it's time for us to really be thinking about it and addressing it within ourselves, with our colleagues, and in our community, and supporting families who are grieving. I know it certainly wasn't emphasized in my training, even though I had a great education at CU Boulder. And there was very little research on bereavement, particularly on children and families, and no freestanding organization that was devoted to serving grieving children and families when my husband Brian and I started Judys House in 2002. I also know that my husband Brian felt very alone when he was grieving as a child. He lost his mom to cancer when he was 12 and felt like he was the only 12-year-old boy who had lost his mom. And this was an incredibly difficult experience for him. And he really felt like he could have benefited from connecting with other kids who had had similar losses. So 18 years ago, as I was finishing up my internship at Children's Hospital, the old Children's and Kemp Center, we started Judys House in a house much smaller than these two that you see in the picture. We had no idea how many people would seek services in a family bereavement center, but we were determined to make it as easy of a door as possible to walk through. Our services are free. You don't need to have a diagnosis. All walks of life are welcome. And most of all, we wanted to make sure that no child felt alone like Brian did. And we believe that the most powerful agent for healing in the midst of grief was connection. As Steve said, I like one of Steve's colleagues said the other day, vitamin C is the new connection, or connection is the new vitamin C, excuse me. I really want to come back to connection throughout our discussion of grief during this pandemic and any time. So unfortunately, Brian was not alone. According to our childhood bereavement estimation model, the CBEM, which you can see at the bottom of the screen, and there's much more information on the CBEM on our website, 1 in 14 children in the US will experience the death of a parent or sibling by the age of 18. And those numbers more than double when you look up to the age of 25. And this estimate doesn't include deaths of other important attachment figures like grandparents who have served as a caregiver or best friends. So it's still a low estimate. And deaths, of course, to COVID and other current public health epidemics like suicide and opioid overdose are impacting way too many families right now. And so unfortunately, these numbers have the potential to increase. At JAG Institute, we're leveraging the CBEM and our other research to help really elevate the issue of childhood bereavement as a public health priority, and to raise awareness about the impact of unaddressed grief and the cost of inaction, if you will, if we don't access and allow folks to access services and supports for bereavement. Like other adverse childhood experiences, ACEs, research has shown that bereavement places youth at increased risk of disrupted development without support. Academic struggles, relationship problems, work problems later in life, mental health and physical health issues. And there's even evidence of earlier mortality for adults who've lost a child or who were bereaved as children, which is important for medical professionals like yourselves who are on the front lines and who are working with families in primary care and other settings. These health issues are often the first thing that are noted, and that can be kind of an avenue to help kids and families and adults cope with some of the difficulties related to grief and related adversities and the secondary stressors and strain of death loss, but also the other moves and loss of jobs and loss of financial security that comes with many of these losses. And the good news is, though, that we can all play a role in preventing these complications and promoting resilience and healthy adaptation. And that's really our focus at Judys House. We're very much a strengths-based program. But each of you also are providing those protective factors by helping kids and families develop coping skills that are healthy and strategies for navigating loss. Neill asked that I make sure that you're aware of our services so that you can refer to us, because we would love to strengthen our partnership with CU and with all of you in the medical field. So this is just a continuum of our whole family preventive services. It's unique in that it is whole family, that it's really a whole community approach to meeting each individual where they are along a broad spectrum of grief and trauma reactions, and with that solid foundation of research and evaluation. So we're helping to raise awareness, as I said. We're educating schools and other agencies throughout our community so they are more grief informed and able to support youth and families who come through their doors. And we do provide intensive clinical training for interns and postgraduates, as well as continuing education to help grow our network of grief and trauma-informed providers in this community and beyond. And then using team-based care, we carefully assess the needs of each individual and the family as a whole, and our care coordinators help to connect them to the right services, either at Judys House or throughout the community. Our core modality is group counseling, again, because of that powerful impact of connecting with someone who's had a similar loss. For instance, unfortunately, we are seeing so many youth suicides now in our community that we have groups devoted to parents who are grieving their child's death to suicide. And unfortunately, even during this stay-at-home period, I've received multiple calls from families who've been impacted by children dying by suicide in the home. We also offer individual and family therapy for those with more intensive or complicated needs. And we serve ages 3 to 25 in English and Spanish, as I said, all free of charge. Our 10-week program, Pathfinders, is where most families land, but we also provide that program not only to the whole family and age-appropriate groups at Judys House, but in schools throughout Metro Denver to reach those kids who are not able to get to us. So I encourage you to look at our website for more information about our programs, our training opportunities, and the written resources that I mentioned. But I wanted to open up this topic of grief, and in general, but also then how this pandemic is impacting grief for so many. At Judys House, we view grief as a normal and healthy reaction to loss. It's universal, but it's also as unique as the person who is grieving. And we don't see it as an illness or something to fix. We believe that people have a natural capacity to heal if they have access to appropriate support. And I think that's the important piece. For some, support is family and friends. For others, that's professional care. We grieve as deeply as we love, but grief is also as complex as relationships are in life. So we feel very strongly that one size does not fit all when it comes to support, which is why we have that continuum of care. We wish grief was as straightforward and time limited as the stages of grief led us to believe, but unfortunately there is no timeline. And there is no right or wrong way to grieve. So it's something that we really need to hold as providers and as people who are supporting folks in our community. For those who have experienced a sudden or unexpected loss, and most of the families at Judys House are, because their loved ones are young when they died, our worldview and that sense of security is often challenged or even shattered for some. And during COVID, which I would say has shattered our assumptive world globally and our sense of safety and our way of living, these losses that folks are experiencing are compounded and even more complex. The losses to coronavirus are sudden. There are many, way too many. It's hard to even wrap our heads around their magnitude. The deaths to COVID are staggering, but add to that the deaths that are caused because people are afraid to seek care, and the numbers are even higher. And the deaths that are forced to happen alone, without loved ones being able to say goodbye, to hold their loved one's hand in those last hours. These deaths are incredibly harder for folks right now, and even harder because we can't mourn together. It's so important. We grieve collectively. We want to gather for funerals and for ceremonies, and people are getting very creative, having funerals, drive-by receptions and video funerals, but we all know it's not the same. It's not the same as being able to be together in person. Time is distorted right now for all of us. We have all kinds of losses that we're grieving right now, losses of jobs, of financial security, missing celebrations, graduations, weddings. It's all compounding for us, and our routines are disrupted. But for individuals who are grieving a death loss on top of those losses, time feels frozen for them. And without the distractions and the comfort of going back into some sort of a normal routine, they can feel even more in limbo. And then perhaps most painful is that inability to have the physical support of our friends and family. So often what we need most of all when we're grieving is that big hug from people who care about us. So fortunately though, there's so many of you on this call, so, and you're all helpers, I know that. There are ways we can help, and Steve and Chip both talked about some wonderful resources for getting help for yourself, for encouraging your colleagues to pursue. But in general, whether it's with our clients or our patients or with our neighbors, our friends and family, some things to remember when we're supporting folks who are grieving is to acknowledge all losses. Certainly the deaths to COVID, but deaths due to other causes. I've had a lot of people say to me that when they've had somebody die recently, the first thing people ask is, was it COVID? Which, when it's not, sometimes feels like people don't care as much, or it's not as important of a loss, almost like disenfranchised grief. And it's important to remember all deaths are hard, especially right now. Don't shy away from asking about all of the losses they're experiencing. This is a time for us to let go of that grief avoidance that I mentioned earlier. Have it be a standard practice that when you're meeting with someone, even if it's about physical issues, to check in. If they're having trouble sleeping, have they experienced significant losses, either death loss or other losses? Ask, don't leave them alone with it, and really listen. I think, like I said earlier, grief is one of those things we need to be careful not to try to jump in and fix. Advice stinks when you're grieving. Mostly folks need to be heard and to have that safety and true empathy being shown to them, and concrete support. Instead of, we all want to say, if there's anything I can do to help, give something specific. Can I mow your lawn? Can I get you some groceries? Can I help your kids with their homework? People who are working from home right now and trying to juggle keeping a job or staying on top of a job and keeping their kids in school and homeschooling need concrete support. So remember that what you can offer in that domain is sometimes the most important thing you can do right now. And that bottom line, again, back to connection, is to really strengthen the real connections that you have with the people in your life and with your clients and your patients and with your colleagues. I hope that one of the silver linings of this pandemic is this kind of collective growth that I think we can all experience if we really are mindful of tapping into that, the power of connection. I know we're all really looking forward to not being on a Zoom screen and to actually be face-to-face again. And it's something to look forward to, and it's something to foster and nurture and never take for granted again when we're out of this pandemic. Which brings me back to our mission of connection healing at Judys House. And I have to ask for your forgiveness because I'm not only a child psychologist, but I'm an artist. And so I had to include my little hand-drawn map for Pathfinders. It's cheesy, but kids like cheese. So there's a reason that we frame our Pathfinders program as a journey with kids and with families, because as a journey, and it's long and winding and sometimes treacherous and often very lonely. But I love this dual symbolism of the cairn because they've been used throughout time, gathered by many hands to help each other find our way, and also to memorialize those that we have lost. It also speaks to the collective wisdom and the importance of learning from each other and leaning on one another. And as we were preparing this panel, Neill made a comment about how a tree can't show its resilience unless it has gone through a storm. And she actually didn't realize I was writing a children's book about a tree in Aspen who had experienced loss in a storm. I love that Aspen are connected underground and that they're actually one large organism connected to each other, and that's what makes them stronger and more resilient and able to weather storms and adversity, much like the staff and faculty of a university, it occurs to me, and all of you have that power of connection through that university connection. We all do. I hope that you'll tap into those connections, benefit from one another's support, and then I also hope that you'll take a lesson from Aspen, which is that their leads get larger when they're stressed. They're trying to bring in more sunshine. They're trying to, get what they need. And I think as helpers, it's hard for us to show when we're vulnerable, but sometimes that's the most important thing we can do to be able to help. So I encourage you to think about what your tell is in poker terms. Know your tell, know your colleagues' tell, be aware and be ready and able to support one another. My best friend is a doctor, a very hardworking medical doctor, and we ask each other, how big are your leaves right now? And when they're big, it's time for a walk in the sunshine, literally, and to be there for each other. And we have all certainly been weathering a storm lately, one like we've never seen, and it's been stressful and hard. But if there's one thing I've learned about humans in this field, it's that we can do hard things. And I'm grateful for all of you for your hard work, whether it's physically on the front lines or through telehealth or behind the scenes keeping things running, because you are truly helping our community heal and find its way forward. So thank you for taking this time to think about all of these issues with us today.
Dr. Griese, thank you very much. I think our leaves have gotten quite a bit bigger during this pandemic. Dr. Epperson.
Great. I'm going to share my screen. Thank you so much. I had a hard time a couple of times there, not tearing up, Brooke, thinking about some of the things that you were sharing, because really grief and loss in so many ways is affecting all of us. And being able to reach out to others and ask for help is something that I don't think that truthfully we're all very good at. I think some of the data that I'm going to show you just about what we've learned in the Department of Psychiatry, working with our colleagues on the front line in the UCH and UC Health system, is showing that, again, some folks are better at being able to reach out for help. And what we're hoping, and David, I want to thank you so much for asking us to be here today, because we really do need to be talking about mental illness. We need to be talking about grief. We need to be talking about what it is that we feel like we need to have support us. We've spent a lot of time talking about resilience, but I think we have to not only talk about resilience and coping, but also about mental illness, because you alluded to this before, that it probably will be, and we're anticipating and preparing that it will be the second wave of this pandemic. And, I think it's important to recognize that even though we want to promote resilience, we can't do it without telling people that just because you wind up having a sleep disturbance or a PTSD reaction or becoming anxious and depressed, that in no way means that you are not resilient. Some of the most resilient people I know are people who've overcome a significant mental illness. And we want to make sure that our languaging about resilience does not inadvertently keep people from recognizing that when and how to seek mental health care. Initially, we started out with a warm line, thinking that we wanted to have a very quick way for clinicians and also folks, students, residents on campus. So we collaborated with UCH on this, but we opened it up to the whole Anschutz campus, a phone line where we would basically have volunteer. Most of our medical students at that point were looking for things to do. A number of them were going into psychiatry and saw this as a real opportunity to try and contribute. Interestingly enough, from our experience, it's not been the most common way people want to reach out and get support. We've only had about 35 calls, and many of the reasons for the calls are very similar to the reasons that we'll talk about people seeking support groups. But we have had calls from across multiple entities, much broader range of people contacting us through the UC Health system, from Poudre Valley down to Memorial, out to the Western Slope, and again, folks here on the front line. So we think that this is something that is going to increase in utilization as we get the word out, and also to some of the statewide projects we're doing. But I did want to give people an opportunity to see something about the UC Health team support sessions. We've had about 62 of these. They've been led by Helen Coons, a lead psychologist in our department. 6 of them have occurred at Highlands Ranch Hospital teams. Others have occurred with UCH. And again, this is virtual support sessions. More than 400 now have participated. Some people are coming back for ongoing sessions. And again, one of the things that I think is terrific is that our nurses, nurse managers, even the nurse residents, care management teams, social workers, chaplains, folks in the command centers, a number of groups and disciplines and units are reaching out and utilizing this support. But we've really found that there are very few physicians that are utilizing this kind of support. And again, we're trying to understand more what it is that our physician colleagues need. And maybe this is just not the kind of process that they want to use. And so we're all ears, and hopefully during the Q&A, some people can provide perhaps some of their insights as to the kinds of services that we could help our physician colleagues with, if this is not a service that they would prefer to use. The themes, again, as you've heard: guilt, fears, anxiety, grief, mental and physical exhaustion. And again, I think this came up with Chip's comments about burnout. People who maybe were on sort of higher on the burnout scale before, this is just going to really kind of set them up for this kind of mental and physical exhaustion that also depletes an individual and can leave them vulnerable to psychiatric problems. Again, issues with families, and then the unpredictability. We know from animal and human studies that the worst kind of stress is unpredictable stress. And so the unpredictability here has been quite a source of concern. Again, just as the group down in Colorado Springs is working to try and have a statewide impact, we do recognize that we're the only allopathic medical school in this state, and really the largest source of psychiatric either physicians, psychologists, social workers, really that we have a state sort of mandate to reach out our public health mission, providing these key and core services, either the phone line or the support services. Steve's done a number of these through ECHO Colorado. We've been lucky to receive funding from Zoma Foundation through ECHO Colorado to provide some of these services. And now the Office of Behavioral Health has a grant from SAMHSA, and we'll be working with them to provide hopefully more direct physician-to-physician care. We've also, if you haven't seen our website, I would very much encourage you to go to this, because it has a number of different resources, and we vet what goes on this website with respect to COVID resources quite heavily before we submit them. And then, of course, again, trying to increase this discussion about mental illness as being the second wave, and using terminology about mental illness, whether it's depression, problem drinking, suicide. This is a new podcast that we started just a few weeks ago. April 21st was the first installment. Most recently, yesterday, was Mind the Drink with Patrick Failing, talking about, again, just, being mindful about how much we're drinking. We're all having happy hours, and that's absolutely a great way to have connections with people. So I think that, again, it's important to have that, but just being mindful about how much one is actually drinking during this stressful time. And interestingly, I just wanted to share one quote that someone sent to me yesterday. It was so sweet that she reached out and said, that she had been meaning to tell me that the podcasts are informative. She says she can consume it easily, and it makes her think, and it offers actionable advice. And that's exactly the purpose of this podcast. So I suggest that if you haven't seen one of them or listened to one of them, that please take us up on, go to our website and look for Mind the Brain. And then, of course, we are providing acute mental health care, and I highlight here the different resources on campus. We have the UCH outpatient department in here at Building 500. We also have a faculty practice. Student and resident mental health has been busy, and then, of course, the Johnson Depression Center. So there are multiple resources here on campus. And I don't know how many of you know, but May is Mental Health Month, and by the end of May, we're going to be announcing, hopefully campus-wide, a new service that we are going to be opening up specifically for faculty and staff, so that you can be seen more quickly. We do find that when we try and roll faculty and staff into our services where we're seeing patients, like UC Health patients, patients from the community, there's often a wait list. And so we're trying to create opportunities to get our colleagues here on campus in more quickly. And we'll be announcing how that program is going to be set up by the end of the month. So again, David, thank you so much for inviting us to be here today. I really want people in this crisis to be thinking about their own mental health and the mental health of our patients, and that there's absolutely no stigma or shame in saying that one is having more of an issue than they can manage alone, and that again is not a sign of lack of resilience or not being able to cope or hack what we're going through now. This is an incredibly unique time, and again, we want to make sure that people are reaching out if they need help. So thank you again, David.
Okay, thank you very much for these outstanding presentations. We have a lot of questions that have come in, and I'm gonna what I'd like to do is to just pose the questions, and any one of the speakers feel free to answer them. I think there are some unique aspects of this pandemic, and one of them is the social isolation that comes with social distancing. It seems to be at odds with the need to reach out to others and to interact with others, to exercise as a way of maintaining mental health. Could you talk about the inherent limitations that are imposed by the pandemic versus the normal social behavioral aspects that we all rely on to maintain our mental health?
Who wants to take that?
All right, I'll start. Other people can weigh in. So it is, one of the things in general that I find, and I think most people find difficult, is how intentional we have to be about everything. So, I miss walking down the hall and curbsiding with colleagues and others, and having that interaction, or sharing a difficult issue with a patient and getting some feedback in a more informal way. And that is, we need that, and we thrive on that. So now what we need to do to be connected and to get that support is to really be intentional and to schedule it in. The same way you would schedule in taking your medications that you're supposed to take, or, brushing your teeth or whatever. Some of those things we're not doing, I guess, regularly. But, that's really crucial. And so that to really structure in that social support and connectedness is really key. It's a substitute. It's not, it's not a complete replacement. It's not, it's not the ability to touch or to see somebody's expression the way you might like. But it really is what really can help us through this. And again, scheduling it in, making it as important as all your other activities is really crucial. I don't know if anybody else has things to add, but.
Chip, I'm sorry. Did you want to go ahead? Oh, you're muted. Okay, I'll go. Okay. I want to give an example, and I am so grateful to Helen Kuntz, who is the psychologist I was talking about, who is running the support groups, because she's also the clinical director for our women's mental health program. And she is one of those folks that's incredibly intentional and is, got us together almost as a group to not only celebrate the promotions of the people in our group, because we can't celebrate together. So we wanted to have a celebration of their achievement. And I think that that's really important. And also too, we looked at the series Unorthodox. I don't know how many of you have watched it, but, two people in the group took on, discussion of the movie or the series, and, we all shared, and we shared a little bit more about our own personal lives and and it was overall a very, intentional event that we scheduled. And so I would say, if there are people in your clinical groups or in your families that are particularly good at thinking about how to schedule these kinds of things, charge them with it. Say, hey, I know everybody's really busy and people will tell you that they're busy, but just put it together. And if you've got people in your clinical group or teams or families that are particularly good doing that, I would just say, please take this on, because they'll be thrilled that they did it, because it's the kind of thing they love to do. And then ultimately people will find a benefit from it. So again, it was that intentionality that I think was really important.
Mm-hmm. Chip, did you have something you wanted to add?
Just a little bit. I think one of the things that we don't quite register with a lot of times is how the social connectedness that we have in our daily lives normally are so unconscious for us. As we move, throughout our day, we go to the office, we do different things. And I know a lot of people on the call are still going in, obviously, to their workplace, but the normal flow of our lives has been completely disrupted. And as a result of that, we have this sense of dis-ease because we don't have those touch points. And like Steve was saying, he misses that as he walks up and down the hall. And I don't think we've often put words to that. So even if we're intentional about our social connections, which I totally support, that's really important to do, we also have to realize that we're losing some things right now that are difficult for us, and we need to recognize and put words to that.
Okay, that's great. Tell us a little bit about baseline mental health and baseline resilience and how this contributes to the response to a stressful situation, especially a prolonged stressful situation like we're going through now.
Well, I mean, that's obviously an important factor. The people that are most at risk, and there was actually a paper that just came out recently from The Lancet, a meta-analysis of different situations in which people had to be quarantined, whether, SARS, Ebola, what have you, or other reasons for quarantine in our recent past and mental health. And again, it was mostly the biggest risk factors were, are you in treatment now? How stable is your mental health right now? Were you just in recovery? Or if you are in recovery from alcoholism or you've been trying to reduce your alcohol intake, the unstructured, unobserved nature of being in your house all alone is something that could really trigger sort of problem drinking again, for example. Or I just heard from our colleagues up at Mountain Crest in the Poudre Valley region that, they're seeing patients come in more acutely ill because they hadn't been leaving their house to go get their medications. And so the acuity of folks that are coming in, and I know that we're even seeing that in our EDs with things like myocardial infarctions and, stroke, that people are so worried about going out and going and getting care that sometimes they're coming in more acute. So the meta-analysis I was speaking about did talk about, the importance that people stay in their mental health care with their providers if they've had previous histories of depression or bipolar illness, that can be also a risk factor. Young kids are having a difficult time right now, very anxious, missing their social interactions. I mean, we all need structure. Think about your kids. When your kids are unstructured, they're unmoored, and that can be very much a stressor for those kids. So even if your child has not had a mental health issue that's been diagnosed, you might be finding that, whatever was going on for them is just now blossomed. And I think that gets back to the burnout issue, that if you had some burnout that was kind of just, brewing, or if you had a depressive episode that was just kind of brewing, this kind of stressor could certainly propel it into being something more serious.
I want to piggyback on what Neill said. I agree with everything you said. And certainly people with pre-existing issues or with cumulative trauma and loss, and we are surrounded by triggers right now. We know this, right? It's every time you turn on the news, there are grief and loss triggers. Anyone who's dealt with anxiety, I had a very astute 11-year-old say to me that life is just one big exposure therapy session right now. And so it's really forcing people who have struggled with anxiety or depression or trauma to dig into those coping skills and that resilience. And hopefully this will be a time where they can really work on developing that. And I want to also add that for kids, for adults, for any of us who haven't struggled in those ways, it's also a time for us to be looking at our coping strategies and skills and our own resilience and really flexing those muscles. Because if there was ever a time to be educating our kids with social emotional learning around how do you breathe through hard experiences and how do you find ways to cope and stay focused and develop your routines that keep you on track. It's now. And with people being home, I know a lot of folks are stressed to the limit and not able to do that. But if we can capitalize on that, I think, again, that's part of that collective growth we could see to honestly help us curb some of the second wave of mental health issues that I agree are coming. And remember that we were already in a behavioral health crisis, and with youth in particular. So now is the time to be focused on that, to be, telehealth is a great resource for families, but also getting families, parents empowered with some of the information around talking with kids about this is key to their long-term resilience.
Mm-hmm.
So, Dr. Griese, you brought up a really interesting point about, or an analogy to your aspen forest and the community that's created. And it prompted someone to pose this question. What are the determinants that push a community toward becoming stronger when faced with a crisis versus the determinants that really weaken a community?
Mm-hmm.
There are many communities that have been strengthened by going through a crisis. I actually think the Department of Medicine and our campus has been strengthened enormously by going through this crisis. And we've developed a clear mission. We know why we're here. We're here to cure the COVID crisis. We're here to take care of patients with this. We're here to get through this together. And we understand what we need to do that as a community. But talk about the determinants that are associated with success or failure in that journey.
At a community level, I think that's a really great question. That's why I mentioned the faculty, because we are a huge community and full of very smart people who can really support one another. But at a community level, I think what we're seeing, and it reminds me, anytime we go through something really stressful, like having a baby for the first time, for instance, you get very laser focused on what needs to be done to take care of your people, to take care of yourself and your people. And I think that's what we're doing right now. I think as a society, we got very distracted by a lot of noise in our daily living, running around from place to place and overscheduling ourselves and too much time on social media, et cetera. Right now, I think I will just go back to connection, that communication, clear communication, honesty, and just really having that genuine, authentic connection is key to not only surviving this, but thriving beyond it. I do think it will bring our community together. I think we're learning how to do all kinds of things online. I hate devices. I'm very anti-device in general, but we needed them now. And I think we all had to really brush up those skills on how to use those tools. One thing I think that will come out of that is that those communities that are more remote, because we know that rural communities, smaller communities that don't have access to places like the Acute campus where they can access physically these services, need more support often. And so to have technology and telehealth platforms now in greater use is something that I think will strengthen communities throughout Colorado. I hope that we're able to really increase access to care and support in that way. And again, really making sure people are aware of resources. Everybody has really been emphasizing that is so key to making sure that we have what we need to go forward and to continue growing.
And it's also important, I think, to consider the pre-COVID vulnerabilities. And this is true for regular disasters as well as the pandemic disaster, in that we've got marginalized populations that had high levels of stress and trauma coming into this. And we're seeing, interestingly, I think we're seeing that these populations are also more directly affected by COVID in terms of death rates, but also just the psychosocial and economic effects in these communities are way more than in some other more affluent communities. And so I think collectively as governments, state down to local governments, we need to be conscious of that. And as a university and a medical school and community engaged groups, we need to reach out to those populations directly, which I know, Neill and your staff are doing and so forth, but we need to make sure we don't forget those populations in particular.
And and again, as Chip mentioned, the research post-disaster, that it's really dichotomous. If you come from a well-resourced community, then there is a much more likely sense that the community will thrive and come together, feel effective. If it's a low-resource community or country, that is less true. And the other primary factor that's held up is leadership. Leadership in whether it's political or natural leaders are crucial to thriving and coming back together after these events. And we see that all the time now today, and even in our university, leadership has really made a difference. And so that's since the time when we really look to leaders, and they really imbue some resilience.
Right.
Great point. Question about particularly vulnerable populations. You mentioned our patient populations, which are more underrepresented minorities and lower socioeconomic status. What about providers? Who are the providers that are at risk? What about young providers with families that are under unique forms of stress during this because their kids are no longer in school, they have to homeschool, they don't have plans for the summer? Maybe individuals that are trying to balance scientific and clinical careers at the same time and have a hard time addressing that balance. What are your thoughts about vulnerable populations and how we might specifically reach out to those vulnerable populations?
I guess I'd like to take the opportunity to address that question, particularly since I agree. I mean, I think some of our junior researchers, people who maybe just got their K awards or trying to finish their projects with their K awards, or, people with, I have an R01 that's completely shut down. And so, there's a real sense of vulnerability that we're not able to do our work, and we're not sure when we're going to be able to do our work. So again, I think it's that uncertainty, and is the NIH going to help support us, with supplements and that kind of thing? And so I think, again, calling it what it is, it's uncertainty. It's feeling unmoored. It's feeling like you're not able to do what it is that you feel sort of most passionate about. We have support groups for faculty that are in those situations, postdocs, trainees. And I would really recommend that people take advantage of those. They're listed on our website. Really kind of think about being a part of a group and talking these things through. And we have some people that are kind of coming on a regular basis to kind of talk about their anxieties. Because I do think that group of people are going to have some very obvious anxieties, particularly about their work and their ability to have a successful career. Again, I think that's a vulnerable group. I agree with you about trying to balance taking care of your children and having your children at home. And people are starting to write about, sort of the sex and gender impact of this particular pandemic. While men seem to be more likely to be coming to the hospital with more severe illness, and, at least in some places, it's more males than females that are passing away from this disorder. The issues related to mental health might have sort of gender biases as well as sex differences, in the sense that, again, maybe the fact that more men are passing away may be more due to their sex, but gender, we know, plays a role in what's your role in your family. Are you responsible for the one that's going to be homeschooling the kids? Are you a primary caregiver? Maybe you're a single parent, and women are more likely to be a single parent than males. And so, again, I think it's just we're going to see, women may be suffering from certain types of ramifications from this. Men may be suffering from others. And I think more people can reach out and take advantage of the different supports that we have in this realm, the better off that they would be. But to be sensitive to those kinds of sex and gender differences as well.
Thank you.
I also think it's important to think about our own individual perceptions of control and how that plays into the recovery process at this point. So I had the lucky experience of going through Hurricane Andrew as a postdoctoral fellow. And I moved there in behavioral medicine 2 days before Andrew hit. And that experience taught me a lot around what maybe some of the faculty, junior faculty and postdoctoral fellows and so forth are coping with now, because there was a huge amount of uncertainty around the recovery process. And one of the things we know from the self-efficacy literature and empowerment literature is if people can identify aspects in their environment currently they do have control over and focus on those concretely, write them down, identify achievable, manageable goals that they can actually identify and see themselves getting them accomplished. This can create a sense of control and empowerment that the rest of this stuff that we can't control is just going to keep on happening in many ways. So we need to retarget and readjust goals relative to the environment that we're in right now. And I think that can be really helpful for people.
Yeah.
Yeah, that's a great suggestion.
I just want to say that when we're talking about hospitals and clinics, and the people that I think I'm most concerned about are actually what, for lack of a better term, are the ancillary staff, the environmental staff, the food staff, because they don't necessarily get the kind of attention that everybody else is getting, and also their economic struggles are well known, and so there's a group of people that when you think about what they're experiencing, decontaminating, dealing with bodies, all those sorts of things, and struggling to maintain their families and community at home. They, to me, are the ones that we're not really attending to in the way that would be best. I think the analogy is to our patients who have similar kinds of lives. And the families that are struggling the most are the families that are, have kids at home, don't have the resources to provide for them, need school lunches, all those sorts of things. And when you think about the cumulative effect of all those, to me, those are the groups of people that really need much attention from us as possible.
Good. That's great. Let's change topics a little bit and talk a bit more about grief. In the healthcare, in the delivery of healthcare, providers deal with grief all the time. We're probably dealing with a bit more now than usual. But help us through what are the constructive approaches to dealing with this in a healthcare setting when it's not just you and the patient, it's you, the patient, and the whole provider group that's part of the grieving process.
Such a good question. And when I spoke earlier about disenfranchised grief, I think that what I hear from a lot of medical providers is that they, even though it wasn't their loved one, it was someone they cared about, they cared for, especially if it's someone they've been caring for a long time. And so, first of all, being aware of your own grief reactions and allowing yourself to feel that, I think is so important, back to that piece of vulnerability. And we're not able to be genuine and with our clients and our patients if we aren't, in touch with the fact that we're human. That's not to say that we don't also need to be able to have protective factors around, compartmentalizing and taking those breaks and knowing, to Chip's point, what's in our control and what's not in our control. But really being honest with ourselves about what we experience when we're sitting with somebody who is dying or who is losing someone very important in their life is key to being there for them and taking care of ourselves too, making sure we don't just kind of brush it under the rug of what I'm dealing with is nothing compared to what they're dealing with, or what, I think we're at risk right now. There's so many hard things, so many bad things, and so many losses right now that I hear a lot of people kind of minimizing their own losses and their own stress and their own grief because they see so much worse around them. And that's understandable, but it's also important that again, we honor all losses and all reactions to that.
And what about doing that as a group? So faculty, nursing, trainees, other providers?
Those trainees especially, I would say, and we train over a dozen interns and postgraduates at Judys House. And I know that when they are faced with these horribly difficult stories of loss and trauma, one of the saving graces of having team-based care and having a team, and I think, Steve, you spoke eloquently about missing that physical connection with your team, and we have to be very creative about it. But that is what gets our young, from our youngest providers to, we old crusty folks, like we also are vulnerable and need to have peers that we can turn to for support. And we can also learn a lot from younger folks too about how they're coping with it. They've got all kinds of new strategies like yoga and mindfulness that are newer to some of us that are later to coming to that. I think absolutely finding opportunities and being intentional, as you said, about creating those opportunities for supporting each other as a group is key to staying together as a group and being a cohesive team that can be helping more people and supporting each other in the process.
Good. This may be a softball question for psychiatrists, but I'll ask it anyway. In thinking about COVID-related illnesses, we tend to minimize the scope of infection that occurs in COVID. And what is becoming clear is that, at least in terms of cerebral spinal fluid, there are PCR positive results in cerebral spinal fluid of the COVID virus. So the virus is at least in the cerebral spinal fluid. I don't know that there are any reports that I know of anyway that it's actually infected the brain, but I would imagine those may evolve over the next couple of months. The question is how do we account for that in thinking through the mental health changes that our patients are going through that end up having these infections?
It's a great question, and I'm so glad that you brought it up because we've focused a lot on the caregivers and people working in our hospitals and families, but I do have serious concern that the inflammatory processes that occur along with, even if the virus is not infecting the brain specifically, any kind of central nervous system involvement is going to trigger an inflammatory response. And it may be one of the reasons why we're seeing more delirium in cases that, from what I'm hearing on our consult service, they're getting consulted on younger people with delirium, not just older patients, which is more typical. So that has caused a lot of concern for us in the department. And I've asked one of the members of our consult liaison program and she was on it already, working with folks that are bringing back patients who've been in the ICUs for a specialty clinic. Those patients, I believe we've put in a pathway that they're automatically going to get referred to our outpatient psychosomatic clinic, or what we call our med psych clinic, because we do want to follow up those patients. There's plenty of evidence from the delirium literature for other reasons that people experience delirium of cognitive deficits being greater in patients who've had delirium, and again, which is the chicken or the egg, were they having some cognitive impairment that was putting them more at risk for delirium, vice versa. So we are going to hopefully follow the patients that have been in the ICU, but I asked her to please work with our folks that are creating discharge pathways to be able to give everyone a referral for a mental health check after their discharge. And so we're working on that now because we would really like to reach out to these patients proactively, even if you weren't experiencing, had a severe enough illness to end up in the ICU or to have delirium, but that you just had any infection with COVID that landed you in the hospital. We want to follow those patients up, both from a cognitive perspective, as well as depression and anxiety and post-traumatic stress as well. So we're working on that, and I do think it's a really important point that we're expecting to see sequelae, mental health and cognitive sequelae perhaps in this patient population.
Okay, good. Let me ask another sort of biologic and psychiatric interface question, and it has to do with the use of protective equipment, masks, gowns, face shields. These are very, very cumbersome, but necessary, absolutely necessary pieces of equipment that we use all the time when we're taking care of COVID positive patients. How do they affect mood? How do they affect resilience? How do they affect our ability to stay mentally fit during this prolonged pandemic process?
Well, I had one response, but it sounded like Steve might have wanted to say something too. I can say one thing that I've heard is that because it takes so long to put on all of this equipment before going into a room, that some of our clinicians have watched people as they code or as they're declining and not being able to kind of feel like that they can get into the room as quickly. And then sort of the level of communication that you have to have through all of this equipment. So I think in the acute setting, that's pretty traumatizing for the provider because it feels very frustrating. I can't get in there right away. I think when it comes to us more sort of not on the front lines, but even just thinking about trying to practice psychiatry and provide a mental health care evaluation in a face-to-face setting, I'm going to have to be sitting there with a mask on. That seems really odd. I mean, we read people's their facial expressions to know what it is that they're thinking. And when you're walking around and you're seeing only this, it's very hard to read what is going on for that person. So while I don't know of any research focusing on this particular topic, I think it's something that we should really be evaluating because it does separate us from the facial cues that we often as human beings, I think, find so necessary. It's in our DNA. It's part of how we interact with each other from a evolutionary standpoint. Is this person a friend or a foe? Are they smiling at me or are they grimacing under that mask? It's hard to tell.
So there's a little bit of literature that I know of in actually disaster responders, hazmat and whatnot. That there, so I can't remember, but there is a degree of hypoxia that occurs from wearing PPE and the like, and intermittent hypoxia has been shown to increase fatigue levels and low mood. And so, there has been a move, as many of you are aware, for emergency responders to always have oxygen with them, and that's one of the reasons. So I think it does make people more vulnerable. I don't think we know enough about how long you have to have mild hypoxia for that to be a real risk factor. But there is some evidence that it does make you a little bit more vulnerable to some of these mood and fatigue issues.
I think it also kicks off an anxiety reaction for a lot of folks. I mean,
Sure.
I've gone into the grocery store with a mask on and felt like I couldn't breathe, and I could feel what could have kicked off a panic attack for somebody who was vulnerable to that kind of those symptoms. I haven't looked to see if anyone's educating the general public on taking a deep breath, getting out of a situation if you feel that coming on, and allowing your body to get back to some sort of equilibrium so that the anxiety doesn't kick off into a full-blown anxiety reaction. I think kids need that education too, because they've been cooped up in our houses for all this time. I just took my son to a doctor he's left our house for the first time in 9 weeks. And it's very, as you said, Neill, disconcerting for them to not be able to read people's facial expressions and to have their face covered and have that sensation of not being able to get a good breath. So I think we're all coping with so many of these things, but if there was a broader education around breathing and dealing with anxiety reactions, that would be helpful.
I also, I love that. And, an interesting case study that I was involved in when the Oklahoma City bombing speaks to this a little bit, which one of the individuals we interviewed was actually taken to the ER with some pretty severe injuries. And she said that it wasn't the injuries that bothered her, it was the medical staff coming to her and the facial expressions on their faces that really impacted how she was feeling. And I think, as a patient with people with all these PPEs on, it might be quite anxiety provoking and scary. I mean, the fact that they have all these things on, and they know that they're pretty sick, which can also be obviously scary, but, they're also interpreting from that perspective as well. So that's important.
So Chip, you led right into the next question, which is what can we do in that patient provider interface when we're masked and have this face shield on and have a gown on and are gloved. What kind of interface? How can we take some steps to relieve the anxiety of our patients? What are some just fundamental how-tos to decrease the anxiety of these patients that are isolated, they don't see their families, and they have a disease, they have an infection that they've read a lot about and have heard a lot of bad things about?
I'm going to punt that to the psychiatrist.
Okay. Well, I was going to say, be clear about the facts. I mean, that's one of the things that we talked about. And, Steve, you can speak more to this because, you were involved with issues around kids with 9/11 and just other kinds of disasters and things that have happened. And Chip, I'm sure you know much more about this. That, being direct about what the real risks are. I think that people get very anxious. Oh my gosh, if I'm in the hospital, I must be dying, because that's what I hear people doing. You don't know what people's fantasies are unless you ask them. So first of all, asking, are there things that you're particularly concerned about? Because I know that this can be scary. So validating that it could be scary that they're there. What are their fantasies about being there? And then providing some clear-cut facts about most people will walk out of this hospital. And there's ways that you can help to diminish anxiety by just asking them straight out, what is it that they're afraid of? And then providing data. People like data. That really does help them, I think, reduce their anxieties.
Yeah, so I would agree. Anticipatory guidance, being clear about what is going to happen, what the steps are, communicating that really is incredibly helpful. I also think we have an opportunity where we may want to think about, so maybe we don't have to go in the room and we can have a little 10-meter telehealth meeting. So that, so that person who was masked and gowned, you now have seen their face and know who they are. Mm-hmm. So that creating more of a, relationship and recognizing that you have to do different tricks in order to support people and help them be less anxious. But I think something like that is a, useful way to.
Yeah. I think that's a great idea, Stephen. I was just, as you were talking about that, thinking about that, because the doctor that was seeing my son yesterday and was a dermatologist, full hazmat suit, full plastic. I mean, very scary for kids in particular, but I think also acknowledging it, like if each provider comes into the room acknowledging, I know this is really weird that you can only see my eyes and you can't tell that I'm actually smiling at you under this mask, and maybe even have a picture either on their tag or with them, like, this is what I actually look like on a normal day, and I look forward to being face to face with you so we can really have that more of that rapport building. But for now, I'm trying to my best to keep you safe, and this is why I look so funny, for a kid, or so scary. I just think being honest about it and diffusing some of that anxiety can go a long way.
And I also wonder about, and this is why I didn't jump in to begin with, because I don't know the protocols for this, but if, physical touch is such a huge comfort. And so if you're hazmated up and you're really gloved and everything else, if it's reasonable and they're allowed to, put a hand on a shoulder or just provide some reassurance in that way, that goes a long, long ways, I think. So if that's allowed, I think that's really fundamental for people.
Yeah.
Well, this has been an absolutely great discussion. I've learned a tremendous amount, and I think I can apply it to the teams of individuals that I work with and also the patients that I interact with. So I want to thank you all for contributing to our collective knowledge here and to addressing an incredibly important problem that we're dealing with professionally, and we're dealing with in terms of the patients that we interact with, and it has ripples in terms of our personal lives as well. So thanks very much. Thank you to the audience for joining us. Look forward to seeing you next week. Bye.
All right. Thank you,
David.
Take care.